To the January 14, 2015 meeting of the Suburban Detroit Joint General Neurology Support Group. We haven't had our speaker here tonight for a couple of years, so we're very privileged to have Dr. Ken Casey, who is probably the most renowned neurosurgeon now, especially for the MVD and the motor cortex, and he'll tell you about the other procedures that he does. He worked with Dr. Janetta as a partner with Dr. Janetta, who refined and developed and the microvascular decompression, and as if you read the cover letter, has done over 8,000 of the microvascular decompressions around the world. And I mean around the world because he travels the world training people for the MVD, and so we're very privileged to have him. And I apologize for the late start, trying to get all my gear ready to go, so turn that off while I...
Go ahead.
Okay, we're going to have, I hope, a little fun tonight, not at your expense, but we're going to try and cover, you saw the title, but we're going to try and cover some of the different areas that are evolving in the care of facial pain. As you know, the group now has not just the responsibility for folks with standard trigeminal neuralgia, but for all types of neuropathic face pain. And that's been the most exciting area that we're working in, because the question is always, why is there neuropathic face pain? What does that mean, first of all? It means that the nerve is firing when it shouldn't be. Some stimulus is occurring somewhere in the pain pathway, and for those who want to come to the bar afterwards, we can go over it at that point, because that's usually the only way it makes sense is if we had a drink or two. But in that pain pathway, of which there's 4 different levels, something's gone wrong. Some of the ameliorating systems have stopped functioning properly, and pain continues in the absence of the stimulus. That's neuropathic face pain, a bad nerve. So if you think about it as bad nerve, you'd all agree that's bad nerve pain. So it's fairly straightforward. The problem is that the medical community is a little slow getting it. So one of the things I want to start with is sort of one of the banners that we've been taking around the world, and that's time in the concept of pain care. So as you know, or maybe you haven't, if anybody, does anyone have family in Florida? I don't want to insult them, but Florida is considered God's waiting room, isn't it? That's where folks go to just take the next step. The problem with that is that that's the mind of the doctor, that the patients are just waiting, and they're just sitting there. And the real problem is that many of the docs don't understand that pain is in the brain all the time. Whether you're awake, whether you're asleep, and those who don't suffer from pain, do we have any caregivers in the room, or all just, okay. The caregivers know that if the person in pain rolls over and smacks you with their hand accidentally, you wake up immediately. Dog sets on your face, you wake up. So your pain system is always alert to the world around you. It's never off. And as I said, because it sometimes confuses people, they'd say, well, if this nerve is hurting, whether it's in my wrist or it's in my face, why don't we just cut it and that'll be that? Because the guy upstairs was a little smarter than that, and he built a couple of layers. So the first layer is the simple, I stick you with a pin, one neuron fires and goes up the brain, and you say, ouch. But if I cut the nerve that does that, and I stick you with the pin, now about 70 to 80 neurons fire in the brainstem, and you get very uncomfortable. The same sensation you get when the doctor puts up the blood pressure cuff and leaves it on too long. You start to feel a little sweaty, a little tight. It's one of the tests we use to assess the pain system in the office, to get a sense of how reactive or really overreactive it is. And please take note, when I'm saying things like overreactive or bad learning and so on, that's not referring to the patient, it's referring to the system and some of the things that the system does. But then there's a third and a fourth layer, and these are much more dangerous layers. Those are the layers that exist like they do in animals, where there's no differentiation, there's no ability to figure out where the pain's coming from. There's just a sense of impending anxiety and doom and concern, and that's the area that we've been looking at when we've been talking about the concept of time in the pain. Because 100% of the pain is in the brain, that's where you actually feel it. And there are animal preparations, not to be gross, that are cut off right here. The heart's pumping, spinal cord goes to here, and we can see the animal recording what appears to be sensation. We obviously, for a lot of reasons, don't put the animal in pain. The animal's unconscious from the standpoint of a drip, but we can see the system firing when we stimulate it, even though we've cut off the lower half of the body. So it's in the brain that you feel it. And then this is it. You say, well, my foot itched, I scratched it, usually stops, although it doesn't always. So what was in is where the pain was. No, pain's a normal experience. So that's what's important. Pain is protective. That is some type of stimulus that exceeds an amount. What's the easiest way? Who in the room is ticklish? Okay, so can you tickle yourself? Can't, can you? But if the person next to you decides to tickle you, a little bit of tickling, kind of funny. They keep it up, like your older sister was a pain in the butt, and she just kept tickling you, and now it becomes a little uncomfortable to the point that it actually gets to be painful if somebody keeps tickling a very ticklish person. So tickle is a great example of moving right through the pain system, just like a light touch with a blunt pin isn't too bad. Push a little harder, starts to get uncomfortable. Push hard enough to draw blood, and it's very uncomfortable. Same concept. And that's important because those gradations you build in. The two, or the many people put their hands up for ticklish, are not all the same degree of ticklish, nor do they all react at the same 1.5 minutes, 2 minutes, 4 minutes. That's built in. So it's learning in the case of tickle. But so nociceptive pain, such as a pin, is generated by doing specialized nerve endings. So there's a whole lot of them, and again, that's time for another day to go over the details of the pain system. Even the medical students get a little bored. I gave this talk to some of the medical students, and one of them was kind enough to come with me tonight because he just fell asleep during the talk. And I told him that the inside was exactly what I thought of his attention span, empty, empty-headed. So visceral pain, pain in your belly, is stimulation of something like your stomach getting bloated or getting cramps and so on, or during a period. But neuropathic pain, again, this is neuropathic face pain. Trigeminal neuralgia is a form of neuropathic face pain. All face pain which occurs in the absence of stimulus is neuropathic. This is a result of nerve damage directly, such as a trauma, automobile accident, or some sort of internal irritation. We're going to come back to what that is. And then you know these terms. These are the terms that patients use. One of the young ladies earlier asked me, how do we go with the story? We give the McGill Pain Scale. For those who haven't seen it, it's a series of words selected by patients and physicians over the years that give us a sense of trying that very difficult thing about how much does it hurt. And depending on your mood and whether you had enough sleep last night and whether you're hungover, you'll say it hurts worse or not. But if we get enough of those words, we can get a pretty accurate picture that week to week, month to month, gives us an idea of in which direction the patient's pain pattern is going, up or down, either in response to treatment or by itself. So the McGill Pain Scale, some of the words that we look for in this particular neuropathic pain is this. Now recently we just came back from a conference in England. Very cool little study with a linguist. It's a lady that's all she does is words. And I wasn't aware of some of the depth of the work till we got going, but they have these little dictionaries put together in computers of 3 billion words. And the words sit in what's called a 10-word field, meaning they went through all the world's literature, took the sentences, and then put the word that we're after right there in the computer with the 5 words on either side of it. So that we can ask, okay, if the word burning is used, in what setting is it used most commonly in the world? And pain comes in about 8th or 9th most common reason that the word burning is being used, whereas house and home and so on. Makes sense, doesn't it? 2 words though that come out very close is electrical, and then that word that you've all heard in talks and so on is lancinating. Lancinating, interestingly enough, at 3 billion words, was only used in a medical context. At no point in the world's literature by any author that you could think of, and almost all of them are represented in this database, was the word lancinating used for something else. So we find that that's a very good word as physicians to communicate to residents and other physicians and practitioners, to specifically nurse practitioners and PAs, about a way to get a handle on, am I talking about nerve pain or muscle pain or bone pain? Because lancinating only gets used in the context of nerve pain, and usually neuropathic nerve pain. So it's an example of a way to try and get the message out. So for the nerve to be stimulated, you got to get over a specific threshold. That's what I was talking about with the pin earlier. And so pain can lead to poor performance. Anyone in the room who's been in pain knows that. Anybody who's in the room now knows that their life changes both physically and mentally, and it impacts your ability to concentrate, as well as sleep, alters your mood, and decreases your appetite. And all of these are chemically driven. We've known that for a long, long time. So, two messages that I want to leave, even though it's difficult. Improper sleep cycles, 2-3 hours here, awake, 2-3 hours there, awake, napping in the middle of the afternoon, will make your pain worse. So you need somehow to follow all those things you hear about on TV. Don't read in bed, don't watch TV in bed, don't make the bedroom an activity center. It's always that when you're flat, you're out. Surgeons get very good at that. We can even do it standing up at the table. If we're holding a retractor, we'll just drift off to sleep, especially if the surgery is somewhat boring and you're not doing it. But the point is that, because if we're doing it, you are paying us to stay awake, you know. But the idea is to get yourself proper sleep. So the discussion with your doctor about even helping a chemical aid to sleep is not inappropriate in the patient with neuropathic pain of any type, but today we're specifically talking about face pain, but back pain, diabetic foot pain, and so on. Proper sleep, very important, because it changes that chemical balance. The other this is the area that's probably the most exciting. In the pain system, the idea was always I stick them with a pin and it goes to one set of neurons in the brain, and on the surface we can actually record and see it. That's the genesis of the motor cortex stimulator, for example. But after a while we began to realize that, and I talked to some people in the room and they know what I'm talking about, even when you're not in as bad pain as usual, you're worried that it's coming back. Those who have face pain worry about the next attack, don't you? You're sitting around thinking, what am I going to do that it's going to go off? Because most of the time it's not you doing it, is it? So you're sort of just sitting there in anticipation all the time. That means your brain is going to go ahead and learn. But every time you do that, it's going to learn just like when you're a kid and you touched a hot stove. Hopefully, hold up your fingers, everybody's hands have all things. Yeah, so none of you needed like 40 touches to get it where you were burning down the stumps. Most times 2 or 3 touches and your brain says, that's hot, that white enamel thing, let's not screw with that anymore. And then you begin to be able to translate it to other objects. Well, unfortunately, if you keep anticipating pain, whether it's back pain or face pain or the pain I feel when my mother-in-law is coming, you begin to think, okay, the situation you were in at the time, I'll associate it now with this classroom, you'll associate it with it. And then all of a sudden, it's all the things in your life keep reminding you about the pain. But in your particular case, the specific one is when wind sets it off, or chewing sets it off. Before you even get into the kitchen, you're thinking, you're going to chew, it's going to set the pain off. So then the pain's already ramping up. Your brain is already starting to create the little chemical soup that is regarded with pain. So you've learned to be in pain. Remember, I asked you earlier to realize I am not saying it's in your head in the sense that it's not real pain. But you do learn to be in pain, and we now can prove this. We've been saying it for 5 or 6 years in the work that we just finished up in England, thanks to our Federal Dummies Association, the FDA. The wonderful people in Washington couldn't do the study in this country. But what we found is there's very specific places in the brain. This is the one that we record for motor cortex, for example. Here's a way station coming up and below with a single stick. Here's the station that fires off if you've tried to cut the nerve. But these others, specifically this one, the insula, the amygdala, and the prefrontal cortex, as well as the anterior cingulum, and there won't be a test on these, but the point is, they're all kind of getting together in a group. They're the ones that decided 2 touches of the hot stove, it's all we need, stored it. Typically it gets stored just next to the amygdala, where from then on, if someone says, that white thing with the gas coming out of it's going to hurt to put your finger in, damn right it is. And your brain says, we don't need to prove that. Problem is, if you start to do it with other things, this little storage area gets kind of packed up, and these 2 guys start to look around for situations where that might occur. In other words, You don't think of burning your hand on a hot stove when you're lying in the bedroom or standing in the shower. It's not the right, what we call the right surround. But here it can be, because you'll begin to associate the water hitting your face. For some patients, sets it off. So now it'll be the bathroom. For brushing the teeth group, it'll be when you go into the bathroom and look at your toothbrush. There was a fella, Tom may know him, Ev Pinio, who used to be a senior person in the board. Ev would think of a hamburger and get face pain. Imagine that. And that's the elephant in the room for him, because who can not think of it? How do you unthink the hamburger? So every time you think it, bam, get face pain. Drove him crazy, but it was, then we didn't know what was going on. I have to admit, some people on the board thought that maybe he was from Princeton, and you know, those people are a little strange. They thought maybe it was Ev, but we now know that it's this kind of thing, because we've been able to stimulate these places magnetically, that's not putting holes in people, and produce pain in normal people. And then we can produce the fear of pain, which is even cooler. I mean, again, to a scientist, it's cool because it proves the theory that these places are driving pain which doesn't exist, because we're using a magnet, we're not hurting anything. So it's called the pain matrix or the pain surround, and this is what it looks like. This is a functional MRI. You're in that MRI that you've all seen or heard or been exposed to yourselves, and instead we're asking the MRI, instead of just the white and the black areas that you normally see, T1, T2, we say to it, gee, look for areas of increased blood flow. And then you map them out. And you can see, like we did on the previous one, the anterior cingulum is here, that area of the thalamus is here, there's some areas in the cerebellum, this is the S1 cortex, and again, these are areas that we can actually see them lighting up in pain patients. Obviously, we also then took some volunteer medical students, those who wanted to pass the course, and gave them discomfort while they were in the functional MRI to see what happened. All of them lit up S1, because that's where everybody feels pain. Nobody who's normal doesn't feel it there. Problem was, they didn't do this. They didn't do the anterior cingulum, and they didn't do the cerebellum. They did do the thalamus and the S1, because that was a normal pathway. So we saw that the patients who were in chronic pain were flowering into other areas. And then you have the connectivity of the controls again. And what's happened here is we've given the patient essentially feedback. They're in an MRI. If you've had it, you knew that it was 45 minutes, and then you had to wait, and then finally to produce the pictures. We have an MRI in Leeds and a second one going in London, where as you're lying in the MRI, above you, you see the image printing out second by second with the image that just got taken. It's called a real-time MRI. So if you go on the internet, you'll see that it's a new device. It has much more scanners. You have a little bit of the same magnetic. But what's nice about it is, from our research standpoint, we can lay the hand out of a normal volunteer, use a laser light till it increases intensity, or a little bit of a cuff on the finger, and we can actually create a change and see it right away. Well, in the face pain patients in particular at Leeds, we just said to them, think about your face pain. What we got was the blossom. And then we told them, okay, shut it off. Just imagine your face is floating off of you. You know, all the different things that we'll do in the second part, mindfulness. But those techniques, no medicines, just those techniques, and after about 6 weeks of training, this is the kind of thing we got when we said, think of your face pain. Now, did they still have pain at other times during the day? Yeah, you betcha. But they began to develop some techniques to turn it down. And that's this, mindfulness. Mindfulness, sometimes called meditation, but now mindfulness, as you know, has taken on a life of its own, has a real place in medicine. And while it was a fad, and before that, people thought it was basically just the guys who smoked too much pot, now people see that it truly has an important role to play in both organizing the psyche for different tasks, as well as in pain management, and in some other disorders as well, specifically irritable bowel syndrome and gut syndromes. It appears to have a huge role in changing the symptom complex in those patients. But mindfulness, when it's working, look where it lights up in some of those same areas. Remember that PAG that I said comes up and below? This is a slightly different view, but the PAG was right here. When we slice this view across, here's the PAG. And then we see some of the areas on the surface in the S1 and so on. But this is a different color because the blood flow's gone down. Red and blue, blood flow's gone up. Yellow, blood flow went down off of baseline. And that's arbitrary. We can make the colors whatever we want. The point is if you say, gee, what's called bold imaging, blood oxygen level dependent imaging, you can decide, okay, if I see more, I'll assign it this color. If I see less, I'll assign it this color and generate these images. So that's confusing on the internet in particular because the Japanese use a different color scheme than the Europeans. And the Europeans and the Americans started out and we're trying to get together and use the same color scheme. So sometimes you'll see pictures that are difficult to interpret without the caption. But this is what you can do all by yourself. So, can you turn out the back light for me, sir, just for a moment? I want you to just try a quick exercise. Sounds just not way. Well, we'll do a different sound. So it's nice, everybody's nice and quiet, right? Close your eyes. And hear the sound? Now, the second time you hear the sound, I want you to listen to the four parts of it. A moment ago, you heard it, you said clap. Tell your brain you have no idea what it is. And you just want to listen to the sound. You don't want to try to identify it. You don't want to see what it is. How many parts do you hear to it? Is that more or less? Can you hear it? Or is it a little too spooky? Well, mindfulness is trying to sit there and focus on something. You've seen on, I'm sure, plenty of movies where it's okay, that's Hinduism, that's a particular thing. Most mindfulness uses sound because it's very hard for us to clear our brains. We sit there and our brain's going a mile a minute. I gotta do this, I gotta do that, oh my God, the face is gonna come, oh geez, the kids got to be picked up, oh, the bills aren't paid, and you just can't shut it off. But if you have a focus, and you're just focusing on the sound that's regularly coming, you can begin to do it. You can do it yourself. You get a gong, a rich gong that has several different sounds. These are all available on the internet. I was trying to get mine up, but for some reason they won't load just now. But it's pretty nice. If you could turn the light back on, sir, that'd be nice.
That gets you to allow the pain, is that like biofeedback where you're
It's
relaxing so you're not feeling the pain?
actually, mindfulness is one step beyond it, where
Yeah.
those pain matrix centers are being told to go negative, as it were. I'll move back in the way. But they're being told to drop their blood flow because they're being tasked to do another topic.
Yeah.
And so we would lose-
So in effect, you're relaxing.
What's that?
So in effect, you're relaxing?
Yeah,
Or that you're focusing on something else.
Yeah.
yeah. Just keep it off again. All right.
I know the biofeedback worked on me originally.
Yeah.
15 years ago.
Real-time MRI allows you to create an amazing thing while I'm looking for this to come back up. An amazing thing that was done is, if you know what an EEG is, it's obviously a study of your brain waves. And most people have thought forevermore that EEG is something that the patient can't really control. We can use it to detect different activities. And what we did with this study was kind of cool. EEG was put on the patients. They were watching their EEG, they were watching their real-time MRI. They could see the blood flow, and we said, all right, turn off the left EEG. But the patient has to be awake to do that because the left side of your brain runs everything in terms of that, in terms of conscious thinking, oh, okay. But they were able to literally drop from what's called the alpha rhythm, the normal rhythm that hopefully you're in right now, down to what's called the delta rhythm. Delta is just a low sleep. These people were wide awake, but they're able to do it on one side. As you might guess, when the word first got presented, the words in the room came out like we had sailors in there. They were all saying, you guys are full of crap. They were using a different word, same 4 letters. But asked some people, fine, if we are, then repeat the study and prove us wrong. They repeated the study, and what do you know? So you asked about biofeedback, hypnosis, biofeedback, mindfulness, the ability to cope with your pain are all in one big bucket. And it's important to remember that you can affect the bucket. So everybody can read the slide, but you can see specific changes in that fMRI signal. And again, the changes are right where we want them to. Mr. Memory, who in the room, when they get pain, get enraged about it? In between the pain events. So I see a couple of head shaking, right? The pain comes and you're like, God damn it, why am I getting the pain? What'd I do? I didn't do anything. Is it a little bit of rage, a little bit of anger? That's your amygdala. That's what it does all day long for a living. So when Governor Snyder says, you know, who cares about the roads? I don't care if people are dying in potholes. There's families living out in some of the potholes now, so be careful when you drive by. They're actually setting up camp. They're down deep enough. But, you know, that rage is coming from that same area. The problem is here, it's being driven by you internally. And you need to see if you can turn it off. But you can see the areas we talked about, the amygdala, pons, where that PAG was, and then the anterior cingulate. We're doing work right now where previously when we were doing deep brain stimulation it wasn't very effective because we didn't have a good target. We now have looked at this little area, the anterior cingulum. We used to cut it, and people would report that although they could now feel the pain, it didn't seem to bother them as much. We had separated appreciation from suffering, and that was useful back then, but the government didn't like the idea at all. They called it psychosurgery or the kind of thing you equate with frontal lobotomies, and basically forced it out of the payment scheme, which usually kills it in an academic center. If you don't get paid, the boss doesn't really want you to keep doing it. But we recycled it because we said, okay, what if we get a better target? And some of the work we just finished, we're going to publish it probably in 2-3 months, depending, is in the anterior cingulum there's 5 areas. In a normal person, only 2 light up in the face of that stick, the medical student stick I talked about earlier. In a chronic pain patient, they light up in a hierarchical manner. Not always 1 to 5, front to back, but one of them will light up first. Typically it'll skip its 2 buddies. You would think, well, one would light up and then it would spread, and it doesn't do that. It's very hierarchical. Obviously, from our perspective, if I can figure out who's lighting up first, odds are that's the troublemaker. And if I can get the troublemaker to calm down, maybe we can win. So what we're looking at is much the same as we do for tremor, where you put an electrode down and counterbalance the abnormal brain signal. In this case, it's firing the cells. We usually, if the cells are firing at 100 hertz, 100 per second, we'll fire back at 105 or 95 and set up a competing rhythm, and many times the tremor will stop right on the table. Well, it's going to be the same thing here. This is essentially, and we say it because insurance people, unfortunately, remember, you're not a customer, you're not a patient, you are a cost center. Who works in a business office here? Anybody in business? Cost centers are where money gets spent. You are a cost center to an insurance company. All you can do is cost them money. So they're kind of fearful of it. Well, we're trying to point out to them that this will be the barcode. This will be the SKU for that person's brain. And we'll be able to tailor the procedure to their particular SKU and hopefully get the SKUs, you remember the brand thing in the supermarket, we'll be able to get a more positive result. We've done a few folks in Europe. We've done a few in the United States. Seems to be panning out. Until Dr. Janetta, who, when you say, by the way, worked, I do want to correct it. It's works. PJ's not operating, but he's still 33 from the top of his collarbones to the top of his head. He's coming up with new ideas you wouldn't believe. So he's still out there pitching. It's just he's not walking. He's pitching and bitching, especially when I'm slow, getting things back to him like I'm supposed to.
Still play the banjo?
Huh?
Does he still play the banjo?
No.
No.
He's having trouble with his hands
Fingers,
in terms of that.
Yeah.
But the point is that PJ feels until you get to 200 of something, don't talk about statistics. Don't say 50%, 70%. You know, when you have 2, 50% is 1. Yeah, not a very good argument.
Same thing with the number of procedures a physician has done before
Yeah.
you
Well, he
select
mentioned, he
somebody.
wanted to know the number earlier, said it
Yeah.
to me. What if somebody has done 8,000 and 7,999 are dead? And one guy's done 10 and all 10 are doing great? Who would you go to?
Yeah, but we know you have.
Everybody would go to 10, right? So
Yeah.
let the problem with asking your physician a number is, first of all, unless they have a fairly rigorous research base, and in our case, we have a PA who tracks this, because we'd never remember PGI. Christ, we just work from drink to drink. We're just working for booze. That's all we do. Irishman and an Italian? Come on. We don't count
What you
anything.
see, I did the same thing.
Yeah, we just go from drink to drink, and in between, good things seem to happen, pure luck. But
Now they're
Ricky-
not gonna pick you as a surgeon.
Okay.
If they take that literally.
Ricky, the PA, and now our current nurse, they keep track of all this. They send out the emails, they track folks down and get the numbers. And not everybody can do that. In this day and age, the overhead of a practice is enormous. If any of you have had the fun of trying to get a procedure that your insurance company doesn't want you to get, there's 53 letters, a couple of appearances, they'd like you to, crawl your way up Woodward like you're going through Mecca. I mean, it's just nuts. So, let's just sum up this area and then we'll move on to the thing that some people are questioning about. So we have this dynamic mind-body response. These are all little brain things. But before mindfulness, thalamus and amygdala get fired up. The thalamus directly, because that's where you feel the stimulus, amygdala because it stores the memory. And then you have increasing activity, and the increasing activity gets you all excited, and you have decreased connectivity, functional connectivity, decreased ability to start to shut the system down. The system has a natural shutdown side. For example, you're running across Woodward, you hop over the median, you fall, you crack your ankle. You can sit there and the next big tractor trailer that comes by will fix your pain problem for you quite permanently. Or you can get up, walk on your broken ankle to the side of the curb, and then collapse in a heap. That was your descending antinociceptive or descending anti-pain system. Everybody's got one. It runs on two chemicals. One's called serotonin, which, to no surprise, while it's living in Turkey in your head, serotonin regulates your sleep cycle and your appetite. So it's no surprise to us that chronic pain patients, whether it's diabetic foot pain, back pain, or this, have lousy sleep cycles, lousy appetite, because they're missing these chemicals. But if you get mindfulness going, now you can begin to turn down some of the activities and get them going in your favor and increase your functional connectivity. And some of the anger and the helplessness and the feeling of rage can be toned down and made to be funneled. Sounds a little hocus pocus, but we can see it. And these are the two areas that's important. And the reason it's important specifically to a surgeon is if you do the world's best MBD operation, patient wakes up and says, I have no pain. If you ask every one of them, and we do, at a month or 2 months post-op, how you doing? I don't have any pain. I'm off the meds. Boy, that's great. Is that it? Any concerns? Well, you get that little face movement and say, so you're afraid the pain's going to come back, aren't you? Oh, yeah. And some of them won't even come off their meds. Anybody in the room who went way down on their meds but wouldn't come off after their MBD? That's very common. They kind of have that last little pill and, bless it in the morning, run around the house with it in their hand, and then finally pop it in, saying, don't come get me, God. Meanwhile, he's up there going, I can shoot a moving target. It's not a problem for me. I'm the Lord. But these are the areas where that happens. So if we don't tell you before surgery, talk about it after surgery, and occasionally, if necessary, treat it, now that we can see it, literally see it on the functional MRI, it'll just be back there in the back of your mind, haunting you forever. The lady who started your organization, Claire, she's 25 years today, or 27 years today from surgery, pain-free. She still worries about the pain. You would think after 27 years, you'd think to yourself, that's not coming back, but she still thinks about it. Okay, and we talked about the exercise. You can look at a candle and get all excited about paying attention to the candle movement, your own breath, and then the sound that you hear. So, this is usually the thing that people have some interest in. What can the surgeon do for you? And the first question is always, are all of the 5, and there's only 5, procedures the same? To no surprise, the answer is, well, yes, because they're all trying to help your pain, and no, because there's 4 destructive and 1 not so destructive, depending on how it goes. So clearly that's a difference. But within them, there are more differences, and we'll try to cover them as we go along. But do understand, especially the younger folks in the room, we've left or are leaving rapidly the so-called ablative or injury-based approach to neurosurgery for pain management. We know intuitively that this is not going to work long-term. As a resident, I would actually cut half of somebody's cord. So I'd go into their neck, do a laminectomy, see their spinal cord, take a knife, stick it right in the center, turn it, and slice the left half of the cord, making them hemiplegic because they're loaded with cancer pain. And for about 3 months, they'd say they didn't have any pain. And then it would come back. But I just cut it. I mean, I watched myself cut it because the system has all those redundancies. We didn't know it at the time. Now we know it. So we know that these ablative systems are probably going to get us all into trouble. And the term that everybody in the room fears, that anesthesia dolorosa, bad term because it doesn't mean to the doctor anything, but if you say de-afferentation pain, no nerve input to a painful site, now we have something. Because we know then that there's nothing in the periphery that's happening. It's what's called the memory engram, or the little group of cells that were made during the pain. Your brain actually makes cells and codes them and says, yep, that's the burning, that's the lancinating, and they cycle. And if they don't get any stimulus, those in the room who get relief from touching or putting a pillow on, or the capsation, or trying to get in some position, those are all the ameliorating factors that the nerve allows in. But if you take all those away, now the engram just runs an endless loop. So it's very important, as we said at the beginning, first of all, it's always happening. You're always in pain. Your brain is always running this little memory loop because remember, it thinks it's protecting you. It thinks it's part of the defense against the outside. Your brain can't make a decision that, hey, there's nothing there. It hears from the eyeball that, you know, the skin isn't searing away. It hears from a few mechanoreceptors that your face is still attached, but it has no way to externally step out and go, what the hell? There's nothing out there. What are we getting excited about? The only thing that can do that is an internal cycle, that functional connectivity. And so we're going to modulation. We're trying to work with the pain system. So we're going away from nerve-based to more emphasis on central procedures. One area where 2-3 years ago I was asked to leave a stage, we were at a group in, because I said, you know what, the MBD should probably be done within a year or 2 of the onset of pain, not 3 to 5 years, not 7 to 10 years. And the reason is very simple. We know 6 hours after pain starts, anywhere in the human body, you change your cells. Now it's a game. How many cells are going to change how fast? Well, that you got to take up with the manufacturer. In other words, she may make, just for the sake of argument, 10 cells every day. But he may make 300. It may not mean that he's in 300 times or 30 times more pain. His descending system may be trying to keep up. But the point is he's making cells. And the bad news about this is, and this is Liz Bullock's work, for those who will look it up, B-U-L-L-O-C-K, they never go away. You get the patient out of pain and the cells just sit there, and all they're made for is pain perception. They have no other function. So now the little brush that goes by on the leg, pain, because a few of those guys get fired up. Somebody gets a Charlie horse, and instead of just a Charlie horse that they try to walk off, they're busy writhing on the ground. So we're fairly convinced, not just face pain, but in face pain, since we have something that works for the appropriate story, need to do it sooner. We can't be sitting on these people. This is heresy to the neurologists, even bigger heresy to the family practitioners, and oh my God, the government is just so pissed off that we're saying this. Because again, you're a cost center. And they can't seem to get their mind around the fact that doing the operation here, instead of 42,000 ER visits later here, with a pissed off patient who may never get better with a family that got wrecked and a whole lot of, they don't, different pots, they can't put all it together. When I talk to congressmen, I'm just seriously concerned that these guys couldn't do anything else in life. They're too stupid. because this is not rocket science. It's not brain surgery. You just sit down and figure it out, if I make somebody better here, they're probably gonna be happier here. In fact, if I pay for it, they may even vote for me.
You know, Dr. Janetta mentioned that the first time in 1998 in Orlando, that was the second conference. And I thought that was just a surgeon. Now, why would I ever question Dr. Janetta? I just heard him for the first
He
time.
wants you to.
Thinking that he's just trying to get more business. But the way I talk to the group is, in my simple, if you put your finger on the bench and you keep hitting it with a hammer, over time it's going to get pretty damn sore. You know, you hit it once, a little bit, but if you keep hitting it, and that in my layman's mind is what I talk to the group, that the same thing would be with the artery on the nerve. If it keeps hitting and hitting and hitting, it's going to wear that sheath off at some point. And I think that's what you're saying
Well, we'll
in
come to
simpler
the sheath
terms.
in a second, but think about, let's use the finger example, it's a
Yeah.
good one. So you've hit yourself with a hammer, and it's really hurting, and now, you know, a lighter blow still hurts just as bad. That makes sense. I mean, you kind of think, yeah, damaging. But you can do this experiment yourself. If you now blow on it, it'll hurt.
After hitting it for a
That's
while.
allodynia. That's
Yeah.
a non-painful stimulus giving you pain. That's what you do when you chew and set off your pain. That's what you do when the wind gets your face. That's what
Yeah.
you do when cold gets your face. So the nerve has gotten so dysfunctional here because Tom got a little excited with the hammer, and the rest of you because of your genetic underpinning, that you're in pain much sooner. So you can see from our standpoint, before all these pain matrices get themselves locked in and all excited and easy to stimulate, which in the animals we can definitely show, and in humans we can see, we gotta cut it off at the pass.
Dr.
So-
Linsky said the same thing in his subgroup and when we had our meeting here in '08. And my only question to him was, and I got a smart-ass answer because maybe he thought it was a smart-ass question, but I said, what about those people that left over time may go into remission? And when he mentioned the response I got, because all of our neurosurgeons here that we would, other than you, because I'm hearing you say this now, are recommending that people try to go on medication as long as they can, and then they said the patient knows when they need surgery. That's the current thinking. I'm not saying whether it's right or wrong. It's a person's decision whether they want to have brain surgery or not. I mean, that's kind of,
That hasn't changed, but
Yeah.
when you say it's the current thinking, years ago, Janetta took on this dumb Irishman who thought, after looking at the data, the MVD ought to be the first thing we do.
right. It's
Well,
a
at the
gold
time,
standard.
Everybody
we call
else
it,
said,
yeah.
that's crap.
Yeah.
We should do the radio
Right.
frequency, we should do this, and
Yeah.
so on. Well, now, there's no doubt that that's what almost every neurosurgeon who does this work around the world says.
Right.
Healthy patient, regardless of the age, MVD is the way to go. Well, that same dumb Irishman has been looking at this pain issue, and I've been saying whenever I can, okay, now, we have data in 4,400 patients with MVD that at 7 years, they just weren't as good, they weren't as happy. They had pain relief, weren't as happy. What is it that we're doing? We're asking you to take an enormous risk, in one sense, in the MVD, depending on your own internal makeup. You know, I don't want somebody rolling around inside my head. What if they see something in there that's not good? And then they'll tell everybody.
Sometimes it takes more than 2 years to get a diagnosis.
That's a separate issue.
Yeah.
Well, if
It
you can't
takes-
get surgery within 2 years if they don't diagnose you, great.
I know, but I'm saying that properly trained, and I do think here Obama may have done you a favor, and if you want to hiss, feel free. But 50 to 60% of all primary care in the next decade will be given by PAs or NPs. You will not see the doctor. They'll manage the chronic, that's already starting. Anybody who goes to a practice of PA and NP knows that the hypertensives, the diabetics, they're all chronically being managed by the NPs now. Some of you may well be, once your neurologist blesses your diagnosis. The government wants that to go back for everything. All intake occurs that way. Well, and we say, okay, fine. The PCPs are overwhelmed. They're trying to think of the zebras. Okay, it's a headache. Well, you know, it could be a colloid cyst. Yeah, except that it's only 0.5% of the entire population. Why don't you start with that one? Why don't you just start with a headache? The NP just thinks, okay, my algorithm, headache. So let me look for bad things, well, and works down. So we're gonna teach the NPs. In fact, we're thinking that at the 25th Congress, or 25th Anniversary Congress, the meeting in New York, we'll have our first CME only for NPs. We gave one in Pittsburgh with Ricky's help, with the PAs. They loved it. We had 300 PAs sign up for a course that only had 150 seats. We had people standing all over the room, and they loved it because nobody else does that for them in school. My point being that we don't want that time to occur. Neurologist just doesn't want to say it because there's no test. The younger neurologists in particular, and the surgeons to be fair, think they have to have a test. But if the patient comes in and says, my head hurts like hell, I have migraine, what's positive on a migraine? Not your EEG, not your MRI, not your skull films, not your blood work. You all get that. Now you're a cost center again. But in the end, they still say, well, you have migraine. This is the same. The minute you start telling us the story, we know what you have. And
The other
that's
thing,
where-
by waiting,
that's
it
where
turns
Tim's-
in, many times it turns into atypical. And that's kind of what
Which
Peter
is a-
said back in
so-
'98, without saying atypical.
At the
He
risk
said
of
it's gonna
offending
turn into
Tim.
constant pain.
Yeah.
Yeah,
Get rid of that term.
yeah, I know.
Make it your
Use the 7
crusade.
categories, I
Because
understand.
atypical really means, in the mind of many neurologists, and this is in their textbooks, you can check it, the textbook just published, Merit, that it's a woman, she's middle-aged, and she's nuts. It says it right there in the book, the word atypical face pain. We don't
Turns into
want that.
constant pain, is what I
Yeah.
should have said, yeah.
What we want is TN1, the classic story, TN2, the aching, burning, pulling, but still in the appropriate distribution, TN3, the same pain in the setting of MS, TN4, I did it. I either screwed around the nerve, you got a block, you smashed into a tree, it smashed your face. TN5, tumors and so on. TN6 is related to disease processes like stroke and so on that knock off the nucleus. And then we have somatoform pain. And we're trying, that word offends the psychiatrists. It again implies that the pain is only in your head. If it's in your head, it's still real to you. It still changes your life. It still pushes you to do things. The problem is you shouldn't have your noggin cracked to let the bad humors out. If you want to read an interesting book, my residency mate, Frank Bertosik, has written a book called When the Air Hits Your Brain. And Frank makes a very good case that whatever you get in your brain open for, you're never quite the same.
The 7 categories he's talking about, we've got a lot of new people here, I didn't want to bounce that off
Yeah,
them now.
virtual.
We've got copies in the back of the 7 categories he's talking about, rather than typical and atypical.
Okay,
They've
so-
split it down into 7
I don't know if
categories.
It's too late, but patients, this is a worldwide thing, not just the United States. Patients with neuropathic pain report on different health scores, what's called a satisfaction survey 36, satisfaction 18. Many of what we call the chronic health surveys always report in any group, whether we put them with foot pain, back pain, atypical angina, which is now called non-operative angina for the very same reason I don't like atypical face pain. The cardiologists don't like that atypical angina because they think, again, it applies nut job, and they can actually see chemical changes now. But the point is that whoever it is, the ones with neuropathic pain, and especially neuropathic face pain, always at the bottom of the group. That they have a poor life. Who in the room with face pain would disagree with that? Anybody? I see some faces I'm very familiar with whose lives are ruled by this. This is your whole existence. And that's not right. Something we gotta do about it. So, economic impact. The spouses of neuropathic pain patients, especially face pain, find that their life is affected as well, and typically their ability to earn money is. So now we're talking about in an age where jobs are going up, but the wages, if anything, more going down. Now we're getting more people who have to leave the workforce to take care of their loved one because they love them. This is a recipe for disaster. Okay, so Sword of Damocles, if you don't know the story, it's an interesting one, look it up, but it's my opinion, it's Dr. Janetta's opinion, and as of 2 nights ago, all 15 of the medical advisory board members' opinions are we should operate sooner. We're just going to keep pushing that. And yeah, people may say you guys just want the money. Remember, most of us are
Don't
salaried.
misunderstand that. That
No,
was
I-
1998.
I know,
Okay,
but
so,
I'm answering
yeah.
this question because most
Yeah.
of us are salaried. We're academicians.
mm,
If I don't do anything all day, I just sit in the office, eat bonbons, and read novels, check shows up every month. Takes the university a couple of years to figure out, hey, we haven't seen that guy do much. because that's how slow it is in those big systems. So my point's important, because lawyers are always like, well, you're just operating to make money, or you just want to do more people to make, no, we don't. In fact, it's the opposite. We just as soon sit there and do nothing. But that doesn't help you. Those foolish ones of us who went into face paint, and I say it because the number of neurosurgeons who are willing to see face pain patients is now following the same trend the neurologists are.
Yeah.
If you, and some of you may have tried to call a neurosurgeon and said, well, I don't do face pain. Go see Joe Blow. Where is he? He's pretty far away. And that's exactly where I like him, pretty far away. So that you have to go to that other person, go to the Cleveland Clinic, go to the Mayo. Don't hang around here, please. So it's happening.
Yeah, we're fortunate in our area to have you and about 3 or 4 other ones. And don't get me wrong, I'm not telling the group that they shouldn't follow your direction.
You know.
I'm just telling you what the latest is from the other neurosurgeons who have spoken over the last couple of years.
I will make it clear, it's not my direction,
Right,
it's a group think.
right.
It took us a long time, and that was my pushing that the MVD should be number one, and I think everyone agrees. Well, I think the same thing with the same fervor. Beauty is, I'm getting close to the end, so I can say it.
Why don't you explain to them who the medical advisory board is and who the people are on that?
In your support group, which has taken on this new group around the world, right now, 15, 16 physicians are sort of advising the physical board, the board of directors it's called, who are businessmen, about medical issues. For example, there was a couple of papers that went out in John Koss's little thing that were incorrect. So we had a retraction come out, or a discussion. We've asked John to show this stuff to us ahead of time. We, for example, the book, it was our decision about a year ago that we needed to update the book. Tim asked me to address that. There are 23 chapters. All 23 chapters are sitting somewhere in some state of disarray in my office at home. We have over, right now, we have over 472,000 words on paper.
This is striking back, right?
Yeah.
So they
It's been
understand,
striking
yeah.
back. The publisher has said, there's no way on God's green earth that 472,000 words are getting out, because that's just way too much. So you can guess what phase we're in. We're in the what has to go, what has to stay phase. But the point is that the medical advisory board are the people just on our phone call the other night. We talked about a couple of problem patients that several of us had either seen or heard of from other guys. Anyway, it's us sort of saying, what do we do with these folks? What can we do for them? How do we get to the next step? So that's the the gene projects of Kim Birchall and the people at Yale came out of those discussions and are pushed by the MAB. Ray Sakula's work that's going on in terms of and Tim mentioned you rub off the covering. That's an idea that's now going away. We think the issue is not demyelination, dysmyelination. You don't make the myelin correctly. And the reason we're saying that is in closed medical societies like Italy, like Sweden, when you picked a face pain patient as what's called the index case, and you looked into their family, what's called the probands, and followed that patient, a higher than expected number got other nerve compression syndromes, either other cranial nerve syndromes, which you've known for a long time. Face pain can get hemifacial on the other side, you can get bilateral face pain, etc. But we started to see higher than expected carpal tunnel, higher than expected sciatica. So once we saw that data, and that was 8-10 years ago, we were like, oh, okay. So PJ talking about the vessel is important, but it looks like, and this was an argument among neurosurgeons for a long time, what about the 25% of people who get autopsy who have a vessel touching the nerve never had face pain? So we had to answer that. Well, it looks like the answer is the genes are different. And so I said some would make 10 cells and some would make 300 cells for just that reason. We're trying to get that work done, but the genetic study is, the first phase is done pretty good. Common question, is there a best medicine? That's the same as, are we there yet? No, there isn't a best medicine. There are a lot of very fertile minds. I think they're all about 19 the last time I met with them in England. They look like they're all 19 anyway. And they're looking at what we call chemically interrogating the nerve. Remember we said we're going to stop trying to cut it and beat on it. So the question is, you can either electrically fool with it, that's my bias, or you can chemically see if you can sort of trick it, which is what we do with epilepsy. It's what we do with Parkinson's. So it's the same concept, but now we're talking about this kind of neuropathic face pain. Problem is, Parkinson's isn't normal. Epilepsy isn't normal. Pain is normal. So if you are having trouble sleeping, as I mentioned earlier, there's a book, 872 pages, called The Molecular Basis of Pain, written by some idiot named Casey. It is a wonderful way to go to sleep. Chapter 1 will put you out just like that. But what it does by crawling through all this is we're looking at these fundamental problems with pain as a protective thing. And so we've said at 2 places in the book, pain is teleologically fundamental to the survival of each of us in the room. You can't be without that system. So we can't shut it off. We just have to figure out how to get along with it. Sort of like the Republicans and the Democrats. I put this up not just because I'm an Irishman, but I am, the people who pay my fees these are my favorites, but this works. I'm not suggesting you become an alcoholic, but I don't know how many times I get a call from somebody saying, I'm in a panic, I'm away from home, sure enough, I left my pills on the table when I got on the plane to go on vacation, or I ran out, what do I do? Alcohol of a certain, in moderation, 5 ounces of wine, about 3/4 of an ounce of hard liquor and so on, does reduce your pain. It's not something you can do lifelong unless you're an Irishman. And then, hey, come on aboard. I love it. But is there a best medicine? No. Should surgery be done sooner? We talked about it. This is what I'm concerned about, though. The neural pathway changes, like I said, but this. Obviously, if Tim was coming over to your house hitting you with the hammer because he has your hand stuck on the table, and you knew every day about 3, here comes Tim with the hammer. As soon as the door opened, your thumb would start to hurt. And then as soon as you heard his car in the driveway, your thumb would start to hurt. So you're learning to be in pain. He's the stimulus, but the stimulus hasn't even gotten to you yet. You're already, that's what you're doing when you've had either successful surgery or worse, partially successful surgery, and you're waiting for that day where you're down on your knees, just wishing that the earth would open up and you'd drop into the molten lava, because that would be preferable to the face pain you have. So that maladaptive learning is, again, one of those permanent things. We can see it affecting other aspects, as I said in some of the earlier slides. So what you have to do is let the box think outside of you, not do what's happening right now. Neurologists, everybody else is, make the diagnosis, take as long as you can. Make sure you get a few thousand teeth out before you do that. Start them on pills. If they come in, give them more pills. If they come in, give them more pills. If they come in, then say, I got nothing for you. And then send them to the surgeon saying, it's not going to work, but you might as well see the surgeon. Who's heard that story? Yeah. It's not true. There are over 55,000 MVDs in our registries. We have our group, Brogy, Sindo in France, Samid and Majid Samid in Germany. So it works. But people keep saying, we haven't done a randomized controlled trial, which is the be-all in medicine. But who in the room has seen a randomized controlled trial of the use of a parachute? Nobody wants to be in the control group. I've got 2 guys standing at the door, you get a chute, you don't. Off you go. No thanks. I'm backing out of that study. Same's true here. We can't open someone's head and then say, on the nerve, and then close, and then say, see, they're still in pain. So we're not going to see a randomized control trial. We think we have an operational control where many different surgeons in many different countries with many different ethnic populations got roughly the same numbers of success for the different categories. To us, surgeons are very simple. See a problem, cut it.
So do you have statistics for the success rate of long-term?
Yes, we do.
After
And-
2 years, if you do surgery
No,
for
we
2
have
years?
it out to 22 years now
So,
from our group.
but I mean, if you operate within 2 years, so what are your stats with that? As far as,
No, it's a good question. What we're asking is the people that we're getting in earlier, here's how we're doing it. When we looked at the original 4,400, we said, what's the natural history following the operation? Well, about 88% immediately say my face pain and good. 12% don't. None were worse. But the 12% that don't, they tend to either get a second procedure or slowly ratchet up over the next 5 or 6 years and require something. But of the 88% who say they're better, virtually nothing happens in our group, and this is true also for Sendo's group and about the same for Grosje's group in Italy. They go to about the 10-year mark, and then at about 1.4% per year recurrence rate. So if you're 20 years out, you have, do the math, a 22% chance that you've had a recurrence. And that's fine. I mean, I tell patients all the time, if anyone's been operating on they know this, you're in recovery and you may not remember, but I tell them, well, the good news is you survived the surgery, and the bad news is you survived the surgery. Because the veins and the arteries, we didn't do anything to them, we just moved them. So they're still trying to wiggle their way around. Look at the backs of your hand. That's where your whole history's written in this. Look how wiggly those are. I mean, you guys are almost too young to, I shouldn't do that. Shouldn't have pointed that.
There you go.
Is there a back door here for me?
Yeah.
You can make
The
one.
point is they get wiggly as they go along because that's natural aging and loss of elasticity, just like you lost elasticity in your skin. So again, you gotta take that up with the manufacturer if you don't like it. But the point is that if we had a bunch of vessels this year, down the road, the rest of the guys that belong there are wiggling their way, sometimes right under the pad or around the vessel from another direction. So you can guess with the first 4,400, we wound up doing about 400 of our own redos based on those numbers over time. And we found that most of the time our redos were veins. And we realized that the
Arteries
time
first time, vein second time?
no, I'll come back to that.
Yeah.
But we found it was mostly veins the second time, and we were underappreciating the ability of the vein. Many of us thought that it just wouldn't sag 2-3 millimeters. I mean, to us, that's like a country mile. But there they were, sagging right in. So Tim just made a comment, is it arteries? PJ's original papers, first 1,000 cases, he said it's an artery 46% of the time, and at first he said 2% nothing, and then some combination of artery and vein. That is now completely flipped. Arteries plus veins is the most common finding in 58% of patients, the combination of the two. That'll be my wife, tell her I'm still.
Yeah.
And then veins come in, so artery plus vein, number one, vein alone, number two. Artery alone is now in third place. And the reason is, in the support group, people are probably the most aware of this. There are many diabetes, but that's the point. We got that from the support group.
I think a lady here found it first. Remember, probably about 12, 13 years ago, wasn't it?
Yeah,
Yeah,
for,
yeah.
minor medicine.
Yeah.
So, dilemma of diagnosis, I don't think it is. I think the dilemma is getting to the right person. That's what your support group leaders do for you.
Mhm.
They try to cull through the community and find the people that A, will listen, because some won't, and B, will actually try to think it through when the story has a few little odd Phillips in it. So, that's an important thing, but otherwise, there's no dilemma. The minute the story comes out of your mouth, you'll see it in Birchall's paper, which is why he has online, do you give them that website?
TNA website?
No, the website from
The
Birchall, where you can
Oh,
self-diagnose.
the questionnaire?
Yeah.
Yeah,
Yeah.
it's available.
The
yeah.
reason something like that can exist with something as big as this is that thousands of patients went into, gee, if they answer this, and this, and the computer algorithm says you have TN1, TN2, trigeminal TNP, trigeminal neuropathic pain, and so on. At that point, he was lumping 3 and 4 and 6 together for the brevity of the survey. It just means that you shouldn't get an operation. It's really what the shorthand is there from Kim's standpoint. And now, and I shouldn't say we, that's too royal. Kim is trying to revise it using data that we're sending to him to try and make it a little more specific. But
He's a neurosurgeon in Oregon.
Yeah.
We should update you on that the next meeting.
So, here's where we are. All the pain is trigeminal neuropathic pain. Those patients who have TN1, classic, sharp, shooting, paroxysmal, short-lasting pain, burning, aching more than 50% of the time, or MS with either one of those two, is the standard group that gets the 5 possibilities of operation. But if you have others, then here's your possibility list. So there are some procedures, is the point. And obviously, if these fail, and I wouldn't say just one, if a couple of them fail, then you would move on. I think Dr. Jen and I are the most vocal about this around the world. even if we do the procedure. If the patient has immediate pain, wakes up in pain, we start with, hey, we're an Italian and an Irishman, of course we miss something, so we go right back.
Open them back up.
Next day, 2 days later,
Is that
depending
right?
on the patient, we tell them that in the office. Because we're human, we're gonna miss stuff. We're either gonna underappreciate it. The other is that nobody knows. We have an idea in the lab that if we take 1 millimeter of the felt and put it in a strain gauge, we can ameliorate a upstroke of 120 millimeters of mercury by 65, 70%. Well, that's nice for science. It says, yeah, felt ameliorates pulsatility. Doesn't tell us for her versus her versus her how much felt we need. So it's always a game of how do I get enough felt in, not to push the nerve out of the way, what's called deviating the neuraxis, that'll give you more pain, not get the artery kinked, not get the felt touching the far wall, because if it touches the dura, it tends to get vessels in it and concretizes, it's called. So how do you do that? So for example, just the other night, John Elksney, very senior fellow, same age as PJ, but with good hips, is now getting away from felt altogether and trying to put a sling of felt, but he's saying not stuffing the felt in, and then tacking the sling to the wall.
Dr. Oxley, does he have that online now?
No, he's only done 6, 7 cases. So we were talking about, there's a big old vein up there called the petrosal sinus.
Yeah.
Not too interested in putting a titanium clip and getting a hole in it. But John says he had one, he had a sort of scramble to get it under control, and the others have gone. But remember that 200 number? 5 versus 200, we're not there yet. But the point is that people are always looking for a better way to do this. And the problem with an immediate redo in anybody's hands is maybe they didn't put enough felt. I have a young lady who's about 17. We did the operation, got a nice big artery, put the felt in. Here was a big vein right on the nerve. You'll see the picture in a second. Just smack against it. I kept trying to move it, and the monitoring people, we monitored both the brainstem and the hearing. The monitoring people kept saying, I tried to move over, nope, don't do that. Okay, not there either. So I finally just stuffed a little bit of felt and said to her when she woke up, look, I didn't really get that as padded as I would like. We may have to go back if the pain continues. She went 3, 4 years, says she's fine. Is it gonna come back? I think so, but he didn't, so he gets to run the show. We always tell the patients, if it goes well, it's him, if it screws up, it's us. But the point is that I didn't think we had enough felt, but apparently the nerve did, and that's all that counts.
Do you find somebody with high blood pressure needs more felt?
No.
Is there a relationship there at all? No?
Not in terms of more felt. What's the problem with high blood pressure is that you tend to get more atherosclerotic changes in the vessel, which makes moving it a
What's
little
that
more-
word mean?
Huh?
That's a sclerotic, or
It
you
means
just said,
that
what's that mean?
Of the 3 walls of the vessel, the middle wall gets cholesterol and then hardening deposits. So instead of being a nice flexible little thing, you gotta sort of sneak past it.
Yeah.
So let me see if I can.
See why I have a collator to help me with my vocabulary.
What's that?
That's why I have a collator back here. She helps you with my vocabulary.
So here's the nerve. This is what the setup looks like. So those who have it, you're on your side, holes made right here behind your ear. And there's the nerve. The young lady earlier asked me, you can kind of see the fascicles here. Nerve is very classic. So we were very concerned, and you'll see why in a second. Here we are looking now at the hearing nerve, and the 7th nerve in front. See that little faint nerve there? And see how they do not look at all the same. But I'd say 5, 10 times a year, we go in for a patient who woke up and he's either come right back or back, and the felt is sitting nicely there because they put it in the wrong spot. This tool, just so you have a sense of reference, and that piece of felt. That piece of felt is 1 millimeter across, and that tool is 2.5 millimeters. So you can see how small the nerve is. But the vessels on it don't need much to get excited.
Do you have to do retraction there?
No.
No.
There's no retraction here. You can see that
No.
the surface of cerebellum is its nice tan. There's no
Okay.
That, however, saying that does not mean that retracting the brain is bad.
Some say
Retracting
that,
too
that's
much is
why.
bad, but
Yeah.
if you use a retractor, if your surgeon says, yeah, and then I put a small retractor in on a piece of felt or on a piece of rubber dam, it's called, that's fine. There's
Yeah.
nothing about it. This is filling the hole now. We've gotten away from the plate, which you got a faint look at there in the corner with the screw. And instead, there's a thing called hydromix, so that the hole's gone, and we're actually remodeling your skull. We started using it in trauma, where people lost large portions of their skull. And now we've adapted it here. Ray's done about 250, I've done 300 with the new stuff. And right now,
Who's Ray?
Ray Sakula, sorry. The leak rate, which is normally quoted, and I still do, at 3%, 3 chances out of 100 you'll leak cerebral spinal fluid through the wound. We'll come back to that in a minute. It's now 0 with the people that we've put this in. We think it seals better. So, again, we're trying to get
Kathy,
ahead.
you know if he used that?
Durability issues, which is what
Didn't,
Ms.
no.
Rupi was asking about. Percutaneous procedures think that they're effective, but this is again the MAB in preparation for the book. They think that overall you get about a 54 to 66% control of pain. We'll come back to what that means in 3 to 5 years. Meaning, in the papers about Gamma Knife in the beginning, they said 90% success rate. If you're getting an operation, would you like to be somewhat pain-free or completely pain-free? Yeah, so for MBD and for all surgeons who do that or percutaneous procedures, our goal was pain-free off medications, pain-free with low-dose medications, 50% or more pain still on medications, no result. Well, the Gamma Knife people just said pain changed, and that was 90%. First of all, that was a lie, but nonetheless, they said 90%. Well, that's not true. It never was 90%. It's always been around 67%, where the patient either said, my pain is 50% less than pre-op, or it is gone. So Gamma Knife does work. 37% will report by 12 weeks that they are virtually pain-free and off medications in all the current large Gamma series around the world. And remember, it's the appropriate time to say this, CyberKnife is not Gamma Knife. There is no credible data that CyberKnife has a role in TNP. It's a volumetric thing, meaning it's looking at a volume, not a point. So no one's looked at the radiobiology, and there's been some really nifty disasters where the brainstem has gotten radiated. So, you know, buying a CyberKnife A does not make you a trigeminal surgeon, and more importantly, we don't have any data that the CyberKnife works. The people who invented the CyberKnife insist they do, and we've always said to them, great, show it to us. And they say, well, I have all these cases. Show them to us.
They don't have it,
I'm sure they had a couple. I'm not arguing that somebody didn't get better, but they don't have a credible data. And the Gamma Knife people, even though I don't like Gamma because I think it's very destructive, it's a one-way street, repeating it doesn't make sense, and those are physics arguments for another day. But the point is that Gamma Knife at least gives pain-free, off-medication relief to 37%. And if you have a bad heart or on Coumadin because you'll clot up 2 seconds after you come off it, or your doctor says, don't even think about the word operating or you'll drop dead, Gamma Knife's great.
Do you agree there's variability between Gamma Knife centers?
Centers? Sure.
Yeah.
Yeah, at Pittsburgh, we had 2 different Gamma Knife surgeons with the same machine
Right.
who had different results.
Right.
And one of the things that might be of mechanical interest or historical interest, the fellow who invented this, Lars Leksell, Swedish neurosurgeon, very, very famous. When he started, he thought, as do all of us, that the pain was coming when the 3 branches come together in what's called the ganglion, or we call it the PBX box, because all the little wires are coming in and then they get all wound around each other and they form a nerve, the trunk that goes out of the back of the PBX box and connects you to your neighbor. So he targeted the PBX box. If you can visualize him pulling the cords out and cutting off the messages, that was Lars' thinking. So all of his original data about Gamma Knife working was firing at the ganglion, not the nerve. So when we were at Hahnemann, we had about a 2-3 year stretch, it's in Philadelphia, where Gamma Knife results are, you know, as I said, about 50-60%, kind of some unhappy patients, because we'll talk about the downside in a bit. So I wondered, what if we went back to targeting the ganglion? So we targeted the next 15 people with just shooting at the ganglion. They had the greatest durability in that far less than 200 study. So It's my understanding that in Europe, they are now converting back to the ganglion target. And there is some talk in the United States at some of the centers to go back either to the ganglion target to start with, or more importantly, the second time around. It makes sense that if you hit the nerve the first time around with the exact amount of energy it can tolerate, then odds are if you hit it again, that's not good. So they're saying, well, what if I come back on my second dose and go to a whole new target? It's about 8 millimeters away, so it's a great target. So, just some of the things. So this is the durability issue, that you get about 3 to 5 years from percutaneous procedures on the whole, and about 55–60% pain relief. Side effects, remember, you're trying to hurt the nerve. So with those 4, you're going to get a degree of numbness. Glycerol, it's about 0.5%. Balloon, it's about 16%. This is permanent numbness. Radio frequency, where you put a little thing in and cook it. Who in the room can uncook their steak? So, if you're doing radio frequency, the goal of the procedure is that the patient wakes up and says, I can feel touch, pressure, but I cannot feel light. So that's not a complication. That is how we now teach the residents to do it. Because John, too, knew it, but he never said it. So he's the guy who's probably done the most in the world. But now that we've gotten it out of him, that yeah, that's the goal, and Andrew Grande, who's now on our board as well as John, we agree that that's the gold standard for it. So it's not a complication in that case of numbness, but I put it up because it is an effect. And the best way to have it, if you're worried about, do I really want that? Have them numb your nerve. If you just go ahead and put the lidocaine on like the dentist does, but this time hit your ganglion so your whole face goes numb for 6 hours, that's what we're shooting for. And a lot of people tell me, well, no, I don't want that dentist effect. I bite myself. I think I look like an idiot, although your family says, well, you always look like an idiot. There's nothing new. No, I mean, your face isn't changed, your nerves don't sag, but so you have to decide, and that's what I like to do with patients, is tell them, here's what you can expect if this works. With the balloon, for example, we tell them you're not going to be able to chew very well for about 4 or 5 weeks because the motor nerve, the chewing nerve portion of the fifth nerve is sitting side by side the ganglion, and you wind up squeezing a little bit. So that's the weakness, and then we just talked about the cranial recurrent pain. Everybody's excitement, especially neurologists, is, oh, if you get an operation of any type, they're going to knock off your hearing. When we started, a long time ago, we lost 14% of the ears on the side we were working on. Obviously, to us, that was totally unacceptable for what's called functional neurosurgery. It's one thing if you're taking out an ear tumor to knock off the hearing, because after all, they want the tumor out. But this is different. So the University of Pittsburgh, specifically Augie Moeller and the group that PJ was allowed us to work with, we developed what are called brainstem evoked potentials. That's where they originated. And that dropped progressively over the years to currently, in the last 1,200 patients, the hearing rate loss is 0. In the last 2,400 patients, it's 0.86% on the same side as the operation. So good monitoring can really save the hearing. Works very well. And we've got a new cocktail that we're trying that is a drug combination that even allows us to go a little further. But the point is you can do that. We've added, and now we think this should be the standard spinal cord monitoring, because you're moving vessels that feed the cord, namely the pons. And if you're moving them and they're creating a little bit of a strain, you'll see electrical changes in the ability of the spinal cord to work properly. Well, nobody really likes to wake up with a stroke. Patients get annoyed, you can't get the money out of them, they're just a pain in the ass for months. They're after me, hey doc, what are you gonna do for me here? How about a discount? No, I don't want a discount. So, that's helped so that we have no strokes in the last 4,000 patients. I'll get one tomorrow now that I open my big fat mouth. But the point is that we're just not seeing it. And that's not just us. All the centers around the world that have gone to brainstem evoked potential monitoring and somatosensory evoked potential, which is word SSEP, say that, yeah, our stroke rate and our spinal cord complication rates are going way down. True complications, infection, 1%. If you take away God's natural protection to infection, namely the skin, you're letting bugs in. The amazing thing is, as Tim was kind of mentioned, we do operate around the world. I operated in Ethiopia. 1,200 bed hospital, no electricity 3-4 days a week. So we had to open the window to get enough light to work. So we had flies buzzing around. I've operated on heads, craniotomies for subdurals out in the open, down in a town called Owasso, where we're just, our light's coming from the sun. Once the sun went down, we had to stop our operative day. Patients did great. I think that the United States has created the bug problem, not the other way around. The world's full of bugs. They'll be here long after we're gone. In fact, they'll eat us on our way out. But I don't think that infection is as big a deal except in the US. So the message that I'm sending you, whether it's you getting an operation or your family, get out of the hospital as fast as you can. Doctors, including myself here, we don't wash our hands frequently enough. Medical students, to their credit, do it about twice as often as we do. Nurses do it about 3 times as often as we do. X-ray techs don't ever do it. Lab techs never do it. Because they wear the gloves and they're like, oh, the gloves are fine. Yeah, and this. There's a study out, and look it up. This is the most bacteriostatic or bacteria-filled agent going. The tie of most doctors. So, get out of the hospital. We let our people go on average about 30 hours from the moment they check in with the operation occurring in between. Not because I work for the insurance company, because I don't, but because they truly wake up and say, on the morning after surgery, it's like, did you just back a truck over me? Right? But by the next afternoon, you're kind of like, all right, I see what he means. This sucks. The nurses are waking me up every time I fall asleep. They must have a camera, and they're waiting for me to doze, and they say, hey, how you doing? I was fine until you just woke me up. Nurses, as you know, and there's no disrespect, they're not allowed to not check you. If somebody says check them every hour, they got to check you every hour.
It's your fault.
Doctor's
I'm not disagreeing. And that's the point. The doctor writes every 2 hours, every 4 hours, because, oh, it's craniotomy, I got to be really careful. You know what? If she checks every hour and 5 minutes later you drop dead, you're still dead. Mine will still go flat. It's like the routine CT after these operations. I always say to the residents, okay, so we get a CT because they look good. And now, 2 hours later, the nurse called and says he looks like crap. You're going to say, well, CT looks good, can't be anything in the head. No, you're going to get another CT. Okay, so we just blew $1,000 there, no good reason. So we try to teach the residents, do the test when you're going to use the information. Do not order routine tests. And as those of you that had surgery recently, anesthesia finally got the message. So you're not getting routine chest x-rays, routine EKGs, routine blood work. Although the other day I had a 72-year-old lady who they made pee in a cup to make sure she wasn't pregnant. I took the really foolish approach of saying, you've been fooling around lately? She said, oh, God, I wish I was, but no. So, kind of a crazy system.
How many of your patients end up with shingles outbreak after?
We've changed what we've done, so right now, in the 1200 group, 0. And I have to admit, one of the problems I may have in that number is they are going home to North Dakota and so on, but they're staying in email touch pretty consistently, as some of the folks in the room can attest, and usually they would bring something up.
Yeah. So what was your rate prior to whatever you did to change?
At Pittsburgh, in the first 4,400, we thought it was around 1.5%, but we weren't using, if the person had, now what we're asking them is, have you ever had a history of serious cold sores, meaning more than once or twice a year? They may get a little steroid dose on day 2 or 3. So we're doing some things to counter the body's natural response. So it's still a known issue, but we don't. So the success, this is a problem. Everybody always says, well, what's the success rate? Very few programs in the country train the surgeons to do all 5. Dr. Janetta was exceptional in the sense that he was the youngest chairman of the United States, ran the program in the United States for almost the longest time, so we're like Dingle, and insisted that we know how to do all 5 procedures. And what was his rationale? Because he didn't want us to be a hammer. If all you got is a hammer and the patient comes in and says, I have face pain, it's like, hey, bring that face over here. Whack. But if you can say to the patient, well, there's this with a little bit of numbness, and there's this with the balloon, and there's this with the glycerol, pretty easy to do. You could be on a plane this afternoon, but you may be back in a year and a half with that MBD or the gamma. You see, if you know it all, first of all, you give them a balanced approach, and you get to pick. Anybody who's been in my office knows that they're almost frustrated with me, right?
Yes.
Okay, because they say at the end, so what do you think I should do? And I'd say, make up your mind. What do you think I should do? I'm not gonna decide for you. And the people I train are the same way. I shouldn't be deciding what you want. I should be giving you enough information that you can say, I didn't like that one, so that's out. He didn't like the gamma knife, because I'm young and healthy, so that